I don't know if anybody's on the phone this morning.
Yep, you're ready. You're
okay,
ready.
Good. Okay, well, thanks to everyone for coming out this morning. Why don't we start by going around as usual and saying who is here on the committee. We'll start in the room and then go to who's on the phone. So,
Steve Ports, HSCRC.
Charlie Harris, Good morning, Charlie Royland, Johns Hopkins Bayview and Johns Hopkins Medicine.
Nicole Stallings, Maryland Hospital Association.
Laura Herrera, DHMH.
Dr. Vino Banti, internist.
Kim Reed Peck, Western Maryland Health System.
Dan Wynn, Care First.
Barbara Brucato sitting in for Dr. Paravemba, who is also going to try and call in, but he had an emergency at the hospital. But Brucato and Associates. And on the delivery work group.
Good morning, everyone. I'm David Sharp at the Maryland Healthcare Commission.
Good morning, Marlene Riley, Occupational Therapy and representing Towson University.
Donna Kenzer, HSCRC.
and Rob Cohen. And is anyone on the phone from the committee?
Betsy Carrier, Maryland Women's Coalition for Healthcare Reform.
Hi, Betsy. Thank you.
Ben Lowentritt with Chesapeake Urology.
Morning, Ben.
I don't know if you can hear me. This is Dr. Paravemba from First Colony Anesthesia.
Hi, Dr. Paravemba. Good morning.
Okay, you can hear me. Okay, great.
Yeah. Scott Inner from Calvert just joining.
Dana Kaufman, Schwartz, Meston Wise.
Okay. Thank you. Okay, so I think you all have the agenda. I thought we're going to start by, we're not going to spend a lot of time on it, but reviewing the recommendations and overview of the report we've been working on. And I also want to highlight a number of the comments we've received, but also if you have any specific comments that you haven't submitted, feel free to say them or continue to get in touch offline. I'll start. I just thought it would be helpful to mention some of the comments we've received because I apologize that we didn't get this report out until Friday. I know it was a short amount of time to review it and really appreciate people taking the time to review it and get comments in. If I miss any, I do have them all, but I thought I'd mention a few of them. Dr. Chisar from GBMC mentioned the need to reward value and recognize who's creating savings in terms of saving population-based costs. Charlie Royland mentioned the need for predictability. A couple of these I actually got in the most recent, in the draft that's out there now. That happens to be one I built in under sustainability. I figured predictability helped with sustainability. Barry Rosen, who's not here. I always look to this chair right here to see if Barry's here, but Barry's not here this morning. But gave some helpful comments around the words for designated health services, so I appreciate that. There were comments about just the phrasing of how we refer to. As you know, we've talked about two different buckets of recommendations. We've referred to them as non-financial and financial. Got a comment about whether there is money associated with them, so maybe it's compensatory and non-compensatory. Oh, Barry is here. Hi, Barry. Good morning. We were just commenting on your helpful comments. I was just going through some of the comments I received, so I mentioned the designated health services comment that you had sent in. Got comments. Marlene, thank you. Got your comments related to the Stark Law and potential for unintended consequences. Dan Wynn provided a couple comments on making sure that we're trying to address incentives for all providers, both employed, for example, employed physicians as well as community-based physicians, which then also feeds into comments we've received about making sure we're clear that it's not just physicians, that there are non-physician providers in whom we're also interested in trying to create incentives for. We've tried to be clear about that, but it's hard as you go through the paper every time you use the word physicians to write in other providers. So we want to be clear that we do have the full spectrum of providers in mind.
Also, we received a letter from the Nurse Practitioner Association of Maryland from Andrea Schramm about provider-neutral language in here. So I just wanted to add that in the same context.
Yeah, and Shannon Idzik from University. I've been in touch with Shannon speaking about that same thing. So we appreciate that. And Dr. Haft, you gave thoughtful comments on organization. I apologize that you may have seen in the most recent draft that went out, there was an executive summary that I think made the document easier to read. So you slugged through it before you had the benefit of the executive summary, and thank you for taking the time to comment on the structure. So that's some comments we received. If anybody had anything in particular they wanted to mention. And the other thing I'd mention, because it's the one big section that changed since the last draft. I mean, there's lots of things that changed, but the biggest thing was, as you know, we had not built in the legal section until the most recent draft that came out. And thanks to working with Peter Parvis, we now have a more complete legal section. So that was an important section that was just missing up until the last draft.
I have a simple question.
Sure.
The principles that we worked on before, are they separate, or has this subsumed those? And we had a list of principles. Quality is important. I think of a different committee. I don't think so.
Well, within the paper, I would have thought that was the goals and desirable features.
I just want to make sure we didn't miss any of them, because I thought the list of principles was really good. And maybe they're all in there. I didn't do a cross-check.
We should do that. We should do that.
Thanks, Dr. Wynn. Yeah, we'll do a cross-check, because there was a lot of thought put into some of those principles, and make sure they're all in here. Yep.
I think to that point, I made some comments around adding something around expediency, getting something started. While it's throughout the report, it's not, I don't think it's listed explicitly as a goal or desirable feature. So getting something off the ground while working towards a longer-term initiative. I know we talked about flexibility and things being implemented at the local level. I think that was reflected in the goals and desirable features. Those are the two that are top of mind for me.
Mm-hmm. Okay.
This is Dr. Paravemba. I just had a question about, there's a lot of mention in the paper about non-financial ways of promoting value-oriented, population-oriented care. But yet, I mean, I think Nicole had made comments that a lot of these, what are referred to as non-financial, require significant financing because sharing of data and creation of an infrastructure to carry out new programs that are population-based basically require funding and money. How does the HSCRC see that type of funding occurring? Where the hospitals obviously have to work under this new global budgeting system, so they may be constrained as to what they can offer. So, I was just wondering what the thoughts are from the group as to how we would begin to implement those population-based strategies that the specialists and primary care physicians may present to the hospitals.
This is Donna Kinzer. The HSCRC has provided some funding in hospital rates for population health infrastructure. We'll call it that for shorthand. There is some limited funding that that the HSCRC may place in hospital rates based on a bill that was passed through the legislature this spring for about $15 million. And we are also, the state is focused on trying to obtain federal funding where possible. Laura Herrera is getting ready to file an application for more funding under the SIM program, and there continue to be a number of federal funding available under ACA. So, I think there's a continued focus on that funding, and also as hospitals, part of the all-payer model is focused on as hospitals are able to obtain savings from deployment of the initial infrastructure, that those savings ought to be reinvested in large measure in additional population health infrastructure. So that's really kind of initially how we're seeing some of the funding occur. I think Laura is going to make a comment too.
Yes, I would just add, in addition to SIM, just with our traditional public health dollars, CDC has been really working and highlighting, population health initiatives, and where possible, wanting to align CDC dollars with other federal dollars, and most recently, even with HHS, the population health is being coordinated with CDC and metrics that public health already has. So we're certainly now trying to align traditional core public health funding around population health metrics with what's happening in the delivery system.
Thank you. Gary?
Yeah, I apologize I was late, and perhaps people have already mentioned this. I had a couple of comments on the executive summary for things to be considered. Mm-hmm. I think the report is susceptible to the criticism that it's not prescriptive, that it doesn't tell anybody that they have to do. And I think the executive summary perhaps could take that on directly and say, in fact, that is what the report is intended to be, not prescriptive, that the HSCRC has dramatically changed the shape of the playing field. Physician incentives really are different than the hospital incentives, but the HSCRC, because of the global budgets, has reshaped the playing field, and that what the report is saying is, okay, now hospitals, MHA, MedChi, go be creative and react to the fact that the incentives are different. But the HSCRC is not telling you what to do, or at least isn't yet telling you what to do. Inherent is if things, if the larger goals aren't met, then perhaps the HSCRC would have to be prescriptive. But there isn't anything prescriptive. No one's saying hospitals, you have to do this, and perhaps the executive summary could come out and say that. Similarly, I think the executive summary and the report is saying there are other ball field changes that ought to be made, that the HSCRC should be dealing with the feds and see if we can get some of the legal restrictions that will inhibit the hospitals from being creative out of the system. And similarly, right now, the managed Medicare population isn't being, the unmanaged Medicare population isn't being managed. And again, there may be things the HSCRC can do on a statutory basis, either Maryland or federal, that would allow or help that to happen, so that the thrust is at the very large macro level, and then allow the players to deal with it on the micro level. And I think for people who will read the report for the first time, it may help to understand there is actually, I think, a theme here that we as a group, we're not recommending everybody do X, right? Everybody has to adopt the New Jersey this, or everybody has to do what Western Maryland did. We're not doing that. We're saying go be creative, but we want to manipulate the field a little. I could have missed it because we're getting this material quickly, and so I think I didn't see in the executive summary a highlighting of this notion that the HSCRC should allow the hospitals to change, I always forget if it's paymaster or charge master, their charge master to be paid for discharge planning and for follow-up. It's in the report. I don't think it's in the executive summary.
Well,
I think it's very significant to avoid real distortions. If it doesn't occur, then the people who are sick and need hospital care are going to be paying for the follow-up care and the discharge planning of the other folks. It is a distortion. It would lead to the self-pay people overpaying. It leads to payers who are doing real underwriting concepts of the chronically ill coming up with the wrong numbers. I mean, you know, they're overpaying for the wrong people, and it's often that's the people you want covered. It will make us look odd compared to the rest of the country. You know, boy, does it cost a whole lot of money to get your appendix out in Maryland. It's because when you pay for getting your appendix out, you're also doing discharge planning and people going to nursing homes to make sure folks there don't have urinary infections, and you're loading that up on people who happen to be at the hospital. So I think it's an important idea, and I don't think it jumps out at the executive summary level, which I'm afraid means it really won't get done.
Yes, I can tell you what happened with that one, Barry. That was, and I was going to highlight as I talked through the executive summary. If you look in the body of the report, since our, you know, one charge of this work group is the alignment and engagement models, and the second piece is care improvement and care coordination, which we talked about a little at the beginning. We're coming back to that today, talking about post-acute. So there's a place in the body of the report that says that's been suggested, but we're deferring it until this next part where we're talking about care coordination. So it was intentionally, it's very specifically highlighted in the body of the report this time that we just are going to incorporate that as we address care coordination as opposed to the alignment piece. So we can continue to talk about whether it should be in this report or the next report, but the idea is just that that was the one thing that it was noted would fall within the care coordination discussion.
Again, at least I offer to consider adding some theme to the executive summary that we're choosing not to be prescriptive, so that it isn't criticized as saying, you know, you're not really telling me what to do, and because we're intentionally not telling people what to do.
Yeah, that piece, so you've raised two things. This first whole piece, I think, is a very good comment. And then I think a lot of people really liked the day when you came up with the idea about care management, and that was, it was not gotten rid of. It was just noted that it might, the time to discuss it might be in this next part of the report around care management.
Thank you.
Yeah. No, thank you.
The only thing I'd add on that second point is I think it goes back to the underlying thing of how we were funding these efforts. Because the more we load up, we discussed this last meeting, the more we load up onto hospitals, expecting hospitals to fund, the harder it's going to be for us to maintain the waiver test. And therefore, one of the things that I didn't see that we had talked about last time, albeit only in passing, is looking at state authority to do more bundling within the HSCRC structure, where you're designating certain payments towards the physician or other provider side, so they're not designated as hospital payments and counting under the waiver, particularly as we move into the second phase. Because there's a lot of things in here, and I agree with Ram's point earlier, the things that we're saying are not financial are completely financial. They need to be funded, they need to be put in place, and if we keep expecting them to come out of where the hospital's doing, at the same time we're looking at a demographic change which is going to require more and more hospital services, we're just going to break that side of the pivot.
Mm-hmm.
I agree with your point, and just on a totally separate track, but at some point, whether or not there could be better alignment with the work happening around community needs assessments and your community benefit dollars to fund some of these initiatives in addition to some of the funding streams that Scott mentioned.
Thanks, Laura.
Rob, if I could, I think to what Barry said about not being prescriptive, but the recommendations or the basis of the report being a springboard for the hospitals and the physicians and the payers to work collaboratively to the best extent possible. And so along those lines, I think that it's important not to spring forward too much, pushing things in one direction or another, but rather to drill down on things. And I had the benefit 2 days ago of hearing Rob and my committee go over some of the just overall summary points of what the report does. But for instance, where you talk about legal barriers, I think that's an area where it's important for more specificity because, for instance, this past session when we looked at the risk, the ability for all the stakeholders to work together effectively and come up with new models, that we've got 2 huge barriers right now, and we need to get around them. And the one is the tort, the risk of doing things differently. And I actually, though I didn't have a sense I was going to be entirely successful, but along with MedChi and others, really pushed to get a higher standard, a higher negligence standard for innovative services that would be delivered in there, under this new system. So instead of just, preponderance of the evidence, clear and convincing evidence. So, at least putting out there something real that could help with this alignment. And then the other thing, which I again mentioned, which I know an obstacle from the physicians that I've talked to and work with is, and I said this Monday, but I'll say it here, is that the obstacle that the physicians have to really, in a serious way without worrying, being able to share some financial information and in coming up with new models. I mean, that's just enormous. So it really feels like more attention needs to be given there. I know there's questions about the Commission's authority, but that message has to be a little more definitive with, and here are some examples.
Thanks, Barbara. Okay, just so...
One quick thing. We had several comments regarding the physician environment. There's some general assertions and statements made in the report. We intend to get some data from MHCC. We really didn't have time to do that in this stage, but we're going to try to put some data in there that substantiates what we've asserted here.
And since we have guests here today, I want to stay on track, but I do want to quickly go through the recommendations. Actually, the one other set of comments that I've received is Nicole and the MHA gave thoughtful comments to the whole paper, so I didn't go over them one by one, but thank you for yeah. So thank you. I wasn't going to do it here. Okay, real quickly. Yes. Mary, please.
Sure. Yeah, I just wanted to Scott's comment about it'd be nice that
I'm colorblind, so I never know. I have no idea what color it is.
Drive with you.
Yeah, no.
Red and green.
It's a very bad idea to drive with me. I scare myself all the time. With Scott's comment, it would be nice if some of the discharge planning and so on would be paid for, not by the hospital or not under Part A or whatever. I get it. But this is an amazing opportunity that we have. I think in the report it talks about woodwork or something. I didn't understand the metaphor exactly, but it was the payers won't mind if those things get paid for because of the hospital's global caps. Right. And therefore, this is an extraordinary opportunity to implement creating a payment for discharge planning, and that you wouldn't get the resistance then from the payers, because what's the difference? Is there everybody's under a global cap? You would if you were creating some new thing to pay for on a Part B side. So if you introduce it on the Part A side and people get to like it and it becomes normal, you then might be able to let it drift over to the Part B side. But to try to get it there to begin with, I think is a leap because it's an extra cost. And here it's this is an extraordinary opportunity because of the global budgets to do things really quite differently.
Yeah, agreed. Okay, so why don't we just we've talked to them before, but I think since we're trying to wrap up, it would be helpful to quickly go through where we are in terms of the potential options that we're suggesting. So I'm on the bottom of, just right at the bottom of page 4. So sharing infrastructure and analytics, improving reporting between hospitals and providers. The idea is that if you give the hospitals and physicians the right information about the link between cost and quality and value, that just providing the information goes a long way, making the practice of medicine more efficient. So the suggestion to use care management, care coordination, and I know in my experience, having done that, that's very helpful to the physician community. In essence, you're helping them on some of the compensatory stuff that the gain sharing helps on the revenue side, but you can help physicians just on the cost side by making the practice of medicine more efficient, and then promoting broad awareness and education of the new model, because while we around this table know about the new model in Maryland, there's obviously many that don't. The next bullet is we've talked just about the differences between employed physicians and community-based physicians, and the thought that for the many physicians that are employed by hospitals and health systems, you have the opportunity just to do the contracts differently and not have them be solely RVU-based. I think at this point they're mostly RVU-based. I know some hospitals have taken initiatives to bring, or refer to them as triple aim incentives, into those contracts, but that's an opportunity with employed physicians. And obviously independent groups can do stuff in terms of how they manage their own workings within the physician groups, even if they're independent. We've talked a lot about the model that Kim and the Western Maryland Health System and BRG have developed, the pay-for-performance model, and the HSCRC working with the industry to confirm that can be done without additional regulatory approval. So a difference between having a pay-for-performance model be quality-based and not strictly based on sharing a savings. So we'll pursue gaining confirmation on that. We've talked about the gain-sharing model that AMS came and presented a number of meetings ago, and I know we've been talking with the MHA and MedChi, and we've all been talking about the opportunity to pursue that New Jersey-type model while at the same time, trying to expand it to include incentives to address readmissions and things that may not necessarily be built into the New Jersey model, but would be consistent with what we're trying to do here. But that's approvable, so that could be a good place to start. And then going to the top of page 5, we're referring it. Now, I think this is the first time the ISSO acronym has appeared in the document. I think we've referred to it as ACO Light or statewide ACO, but just not to confuse anyone, that's what we're talking about here, this notion of creating a structure for the non-ACO, non-Medicare Advantage, Medicare fee-for-service patients in Maryland. So this concept we've talked about of picking up the set of waivers that apply to ACOs and dropping them on top of the fee-for-service system in Maryland, so that in Maryland, hospitals would have the flexibility to do shared savings models with physicians related to, and other providers related to, the Medicare fee-for-service population. And that's consistent with the regulatory guidance that was put out in 2011, where these waivers were given to ACOs, specifically highlighted that CMMI envisioned giving those packages of waivers to other CMMI demos that had consistent incentives with ACOs. In Maryland, basically what the Maryland system is. I see Charlie holding his mic.
Yeah, so Rob, thanks. Maybe you could just clarify, does that then mean that the hospitals could pursue something like that without either joining or becoming an ACO? Is that what that concept is?
Yeah.
Yeah,
So,
I'm trying to understand how exactly.
So I think the one of the concepts is that if we start having 20 or 30 or 40 or 50 ACOs formed in Maryland, that it could actually be a deterrent to alignment of incentives, because it actually creates an additional layer of confusion for physicians. Because especially in the areas where they might cross from, let's say that they were hospital-centric ACOs, and we have a physician who wants to go to GBMC and St. Joseph and Good Sam, and there's 5 different ACOs, and they all have different shared savings rules and paperwork, and so we're really focusing on the idea that maybe there's some other approach that could hopefully allow for a bigger thought process that has more common measures and approaches and forms and data collection that could be more friendly toward the idea of alignment, but not prescribing that as the only way to go, but to Barry's point, but to say, this could be an option, and can we explore this? Should we explore this? Because this could it could also result in savings of administrative costs, because ACOs are very expensive to form and manage, et cetera, and so forth. So, could we go down this road and avoid some of the expensive administrative costs that can be incurred with individual ACO organizations? So that's, again, not prescriptive, but do you have some thoughts about that?
No, I'm just trying to wrap my head around, so for Hopkins Medicine, we do have an ACO, about 25,000 members. I'm just trying to, I've had to spend some time thinking through what that would feel like to have a statewide ISSO in the context of also having an ACO. I just have to spend some time with my brain on that.
Well, one of the things that the concept is at the beginning. We're still thinking about it, but I think the concept is at the beginning, it would only include the regulated dollars. So in other words, it would give you the ability to do shared savings underneath your global budget. And that would be an easier ask to CMS, CMMI, OIG, whoever we have to ask, because we're just saying, look, we have global budgets. We're under global budgets. You might as well give us the flexibility and the tools we need in the toolbox to make it work. At least in the short term, you don't need to calculate the savings related to Part B and all the other dollars. So it's still an actual ACO, at least in the beginning, brings in the rest of the dollars. So that might be a part of the discussion.
Do we know with the 15 ACOs and the Care First Challenge Round 1 and with JCHIP, how many are still unmanaged fee-for-service? Do we know how many?
We've guessed and said if there's, I don't think we know specifically, but I don't think it would be unreasonable to say we're in the zone of 150,000-ish people. No, managed. Managed. So if there's 800,000 Medicare beneficiaries in Maryland and 650,000 unmanaged, I think it would be fair to say it's the substantial majority are unmanaged.
A couple of thoughts is, one of the big challenges with ACOs around the country, in fact, perhaps the biggest, is attribution. And if you're talking about, okay, this only applies to those, and ACOs are joined not by patients who are not belong to them. They can go anywhere. It's one of the features that are bugs, depending on your perspective. But they do tie up primary care doctors into an ACO. So if you're talking about not having an ACO, but only just a way to shared savings for Medicare beneficiaries under the regulation, how on earth are hospitals, the Medicare's got a problem figuring out ACOs. How are hospitals supposed to figure out which patients get attributed or not?
But in a sense, I'm just thinking off the top of my head, but in a sense, that to me is the beauty of this concept, that it's more population-based. In other words, you could look at it and say, we have in this zip code an X% market share, and we could measure days per thousand for CHF or COPD in this zip code, and you don't. In a sense, it's population-based. It's not patient-based.
I love the concept. I don't think the way you're describing it interacts well with an existing ACO. And the challenge, if you're not going to allow the ability to get additional federal dollars from savings to Medicare, I can't wrap my head around how that actually works.
So this is probably a big topic that we're not going to solve today, but we should add, so this is one of the recommendations, is for us to pursue and look into this. It will be an absolute process of working collaboratively through MedChi and the MHA, and we should think this through. I think I kind of have my head around it, sort of coming from the insurance side, that you got an ACO and people are attributed to that. The people that aren't attributed, you can almost price it out the way you pretend they joined a Medicare Advantage plan.
But you don't know attribution for months afterwards.
So I think in a sense it looks more instead of being in a hospital-centric model, it's a patient and more physician-centric model. So that's really, conceptually how it differs from an ACO that might be sponsored by a hospital. So it does need some more vetting, and I think one of the things that Barry was saying, that we aren't being prescriptive here. I don't think we're being prescriptive, but if we actually are saying, HSCRC work on this option, it is going to require resources from the HSCRC to work on this option and to vet it a little bit more, because it does require vetting. But so I think while it's not prescriptive, we are asking for a devotion of resources to work on things, and we need to take that into account, because we're resource. I won't say we're resource constrained, but we have resource allocation issues like everybody else. So I think that is what is being said here, is pursue something that isn't necessarily hospital-centric or provider-centric, that's a little broader, and that might help walk us down the road toward phase 2 of the model.
Like I said, I love the concept. I just think the limiting it only to, I love the concept of a population-based, community-based, even state-based ACO. But I think if you're trying to really limit it in terms of that, it's not any additional money in terms of a double share.
We're not actually saying
that. We're not trying to limit that. That's it's an easier. It could be that that's an easier place to start. It's an easier ask. It's not where we're trying to go. Absolutely.
Right. I don't think that there's any limit on expanding it to all cost, total cost of care, because I actually think that that'll be important to get into long-term care costs and other costs that are outside of the hospital arena. And we have guardrails that say if the costs go up outside of the hospital, and it causes the total cost of care to go up above the national rate of increase, that's a problem. So I do think that the costs outside of the hospital will become a focus sooner as opposed to later in the life of what we do in Maryland. But to say we could at least get out the door by getting the initial focus on making sure that we can work with the hospital side of the equation quickly, hopefully moving into, I will call it the second part of the activity of getting outside of the hospital.
I just wanted to add, I think this option would be very beneficial for the integration of care with the other community-based providers, such as you just said, long-term care, and it also avoids creating this silo effect throughout Maryland where you have all these, 30-some ACOs that are going to try to be developed.
Right.
Yes, which, I mean, we've been living in silos for healthcare delivery for years now, which is, I think, one of the important pieces of this waiver is to get away from that, which I think this is a great option to be exploring.
No, that's the idea. So just two final comments before we transition over and hear from Lou Grimmel and Dr. Scott Rifkin. Oh, I'm sorry, Dr. Haft.
Just one comment, and it kind of goes back to my stethoscope ears in, and the term prescriptive really sounds like prescriptions. And I really think that we shouldn't abandon the idea that to the extent possible that this document and the work here should be prescriptive. I recognize it can only be prescriptive to whoever we have province over, which would be the hospitals and the things that HSCRC are allowed to govern. But to the extent that that's possible, I would think, given deference to the time frame that things have to get done, it should be as prescriptive as it can be. And if this structure is something that should be pursued, that maybe should be said shall be done. As many things as should be done in the time frame that they should be done in, I think should come out of this. Otherwise, not much happens after a couple of years.
Well, I think that was kind of the point that I was also trying to make, is that while it's not prescriptive exactly what should come after this, if we're saying that the HSCRC should work with A, B, C, D, and E on these 5 recommendations, it actually is prescriptive. If we're going to ask our commissioners to say, go forth and work on these things, because it takes resources to do these things. And so if we're going to ask our commission to help work on these things with other state agencies and with the industry, it is sort of prescriptive in terms of what we're asking the commission and the staff to think about having the commission authorize the staff to work on various things. So we are asking them to take a prescriptive step very clearly. So I would agree with your characterization.
Thank you. The only other thing
I think, Donna, the HSCRC should be prescriptive to the extent that they facilitate the development of these population models. I think when it comes down to the actual doing and treating a population around a hospital, I think the physicians and the hospitals have to decide what would be the best methodology, but they have to have the tools, and the HSCRC would try to create that environment that it can be done in, by creating the waivers. And, for instance, if we're going to do this ISSO type of model, potentially the physicians in the hospital could share more information, and some of the legal barriers that exist in the hospital for different types of physicians to come together and share cost data and so forth. Maybe those could be waived so that you could really work to get a more population-based model in place.
So reading, this is a physician engagement committee, so reading this through the lens of what might be threatening or put doctors off, assuming some of them will actually read. If they read anything, they'll probably read this first few pages. So I'm a little concerned about the service of catalyst for hospitals to revise existing physician employment contracts. When I read that the first time, it didn't sit well, but I just let it stay there. But it's still bothering me. If it's bothering me, it might bother some other doctors. second option. And the other, one way to be...
You're saying it feels one-sided, that the hospitals could sort of unilaterally do that?
It'll be read, no matter what it says, it'll be read differently. So we will want that.
Certainly, MedChi and some of the other physicians have posed concern with those comments regarding, hospital contracts, and I think there's just an error in feeling that potentially, and this is just a question, is would the HSCRC actually be, stipulating certain things that have to be in these contracts? I think that was kind of the fear that, or would they just be generally creating, some suggestions as to how contracts would be in place, or what would be in the contracts for hospital physicians or other physicians?
And that's something that hospitals could work with doctors to do, but to have it as an option, there's only 5 bullets here, and that's one of them.
Right.
I don't know, other people may see it differently, but it seems like it wouldn't promote engagement. It might promote fear.
I mean, I think the general concept is that the contracts are very much RVU-based, or volume-based today, and I look at what sort of Kim
Nothing to do with the facts.
has done.
Nothing to do with the facts. It's all about perception.
Okay, so think about
So
that.
I think we could soften it a little bit so that it's not, that the HSCRC can encourage providers to adopt the triple aim in their contract, so it's not hospital-centric, and maybe there can be some models shared in the state that would be more best practice models, or different practices of how it might be done. So I think I hear you saying soften it a little bit.
That was exactly what I wanted to point out. As a matter of fact, I think I saw that language in the summary, Rob, that you presented Monday. So I put just some bulleted thoughts down, such as, quality and efficiency protocols can successfully be tied into fee-for-service models. I mean, there are things out there that you need to say, that are positive. Fee-for-service doesn't universally drive volume. I mean, look at all the physicians that don't drive volume, like anesthesia or radiology, when they're responding to things. But this really did jump out at me as, oh my gosh, what do they mean here? So, even if you could say something on the positive side, like that first, the first bullet I suggested, quality and efficiency protocols can successfully be tied into fee-for-service models, but, something that gives some level of comfort.
One other thing that might actually make it easier to swallow is removing the word employment, because it's not always employment agreements. It could be contracts with other providers or groups in the hospital, or even vendors, that the hospitals and everyone in the system should look at migrating their contracts to match the new direction they're going to do.
It could be with insurance companies, it could be with anybody. That's a really good idea.
And I just wanted to clarify, based on one of the comments, is I don't think we ever anticipating dictating what those contracts should look like. I mean, it's not our role in each hospital. I mean, the hospitals are on the hook, under the all-payer model. They know what their community looks like. I just wanted to clarify that doesn't mean that we would be creating any model, a model contract or anything.
Again, this is a physician audience, and they would say that's what people always say before they do it.
I think it's a good point, and in some respects that recommendation is more aimed at hospitals who have said, oh, we need gain sharing, but then when you inquire, they haven't changed their contracts yet, and things that they can already do under the existing laws have not been done, and they're asking for gain sharing, but they really haven't done the things that they can already do under the law. that are very positive toward alignment. And so we want to make sure that we promote the idea that there's a lot that hospitals and physicians and payers can do under the existing laws to promote alignment under fee-for-service systems, which, as I think Barbara did, we are not attacking the fee-for-service system, and we don't want that to come out in any way. So I think that's a good point, and we can try to reframe it.
Okay. So just in terms of the agenda, we have a meeting on June the 25th, so unless I hear otherwise, I think it's okay since we're running. This has been a really good and helpful discussion, but we have a meeting on June 25th, so I think it's going to be okay if we don't have time to move the last item on the agenda to the June 25th meeting. So with that, we can turn it over to the post-acute discussion and leave time for that without feeling like we're just time constrained.
Can I ask one more question about process? I apologize.
Sure.
So a draft will be, or a report will be sent to commissioners tomorrow in advance of next week's meeting. Will there be a separate staff report, or is this the only report on the topic?
The staff was drafting the executive summary, and we're intending to make changes to it and turn it into the staff report. So, so we were actually culling up the information and doing this executive summary.
Okay. Well, thank you to Lou Grimmel and Dr. Rifkin for being here this morning to talk about post-acute care. They both have long histories in Maryland working with many aspects of post-acute care. And first we'll hear from Lou.
Good morning, and thank you to the Commission for the invitation to share some of my thoughts on this new and exciting time in the state of Maryland. Some of you in this room may know that there's a new game in town, and that's our new waiver. I think the new game is, I think it's similar to a compound fraction. Look at that, everybody's pulling out. Of course, I don't even know if they have slide rules on anymore. You take your iPhone and you turn it sideways and you get all those calculations. It's a very complicated fraction that nobody really understands, but if you start working through that, it will come up to a solution that you do understand. There are 45 hospitals in Maryland, and that slide depicts the 45 hospitals in Maryland under the old system. There's those same 45 hospitals in Maryland under the new system. Talk about disruptive innovation. There are 233 nursing homes in Maryland, and I believe some of those nursing homes, not all, but some of those nursing homes can be a big solution to some of those problems contained within that compound fraction. Actually, we think that the skilled nursing facility can bridge patients from the hospital into the nursing home, and then from the nursing home out back into the community and community-based services, assisted living facilities, and stuff like that. The issue here is how much do hospitals, who are now holding the responsibility and the dollars, how much do hospitals know about nursing homes? This is what my perception is of some of the hospitals, what they know about nursing homes. Nursing homes have nursing home liaisons who take cookies to their discharge planners and their social workers to get patients. And nursing homes say, of course, we can do whatever you need us to do. So since this is a physician alignment work group, then we know that compound fraction, we know physicians are in that, very heavy in that solution. So there are two large groups of physicians that hospitals employ. And hospitals employ emergency room physicians, And emergency room physicians, by definition, they have a very short stay, a short time with a patient. Although there was an article in this week's Baltimore Business Journal about Sinai's ER, emergency department, and how the director there, the physician who's been there for 22 years, knows so many of the people because they're regulars. They keep on coming in, I guess because, according to him, because there's no place else to go. Those physicians, the emergency room physicians, are working with Maryland Health Access, and they're working on programs to try to unclog those emergency rooms. But if you read that article and if the emergency room doc recognizes a lot of those patients who he only spends a short time, he or she only spends a short time with, how about the hospitalist who spends sometimes 3 days with that patient? So the patient who doesn't go is not admitted to the hospital, and they're working through systems. They stay in the emergency room sometimes for 24 hours, and then they find someplace else for them to go. They're not admitted. What about the low 25%, low acuity, 25% of those patients who do have to be admitted because they may need hydration? They may need certain things, and they can't just send them home, so they admit those patients. So if we look at the definition, and hospitalists are obviously a large group and a major asset to the hospital, but if you look at their definition, their whole being was to practice medicine so that it obviously has the effects on the patient, that the desired effects, but also with the hospital in mind. So here we are in 2014, and when you look at that definition, the hospitalist is all around the hospital. And what's happening today? We're changing hospitals and how hospitals operate. The term hospitalist was coined in 1996. None of this stuff was thought about in 1996. The iPhone didn't come into play until 2007, 11 years later. So I believe the key to the success of this endeavor is the hospitalists need to know more about the nursing home, need to be involved in the nursing home, needs to know the clinical capabilities. They need to know what's going on in the nursing home. And we go back to that original slide where the hospital and the nursing home can play a big role, but it really is, in my opinion, comes down to the hospitalist having exposure to the nursing home, knowing the nursing home's capabilities, and knowing and carrying forward the services that were started in the hospital. So there are opportunities for the hospitalist to connect in the nursing home model. You know, care coordination, verbal handoff, hospitalist. There's all kind of things that will improve the outcome, lower readmission rate. I'm sorry, there's one there. They also can they can be considered as medical directors. They can do the resident risk meetings. They can do utilization review. The whole point here is for the hospitalist to know what the capabilities of the nursing homes are, not just to listen to a third party, but to observe it firsthand, so they can refer to a nursing home with some confidence what capabilities that nursing home has and what capabilities they don't have. I just took a county as an example, or random, and Harford County. In Harford County, there are 2 hospitals. Upper Chesapeake owns them both, and there are 6 nursing homes. And remember when I go back to the slide where I said 233 nursing homes, and some nursing homes can help be a part of the solution to this issue, this problem that we have. So what we did was draw a 5-mile radius around each nursing home. But if I am the hospital and my hospitalist, and I have a contract with my hospitalist, do I need to, all 6 of those nursing homes, am I going to refer my high acuity patients to each one of those 6 nursing homes? Well, I say maybe you don't need 6. Maybe you don't need 4. Maybe you need 3. So to make this thing more manageable for the hospital and the hospitalist, and to be able to control quality and clinical capability, then we have the hospitalist partnering with the hospital and the hospitalist partnering with their post-acute provider based on certain criteria that the hospital would set. This is just, a broader trend. These are some of the health systems that are going to it, and everybody knows that the Ascension Health, but nobody's doing it the way Maryland does. I think that we have an opportunity for Maryland to really be on the board to set the tone for healthcare, and I think it's a very exciting time.
Thank you. I guess we can come back to questions after. I guess we can hear from Dr. Rifkin now, and then we can take questions and comments after, and we'll hear from Nicole as well.
Rob, thank you. Panel, thank you. Can you guys all hear me? I'm not going to try to speak into the microphone. I've got a pretty loud mouth to start with, and I think I heard a familiar voice over the intercom. Was that Thomas that I heard over the mic at some point? No? No. Okay, never mind. Okay. Let me give some background if I can. Mid-Atlantic Healthcare owns and operates 18 facilities in and around Maryland and Pennsylvania, basically. We've got 3,400 beds. We're growing at about 40% a year. We've done that for about 5 years. We're going to announce an acquisition of another 5 or 6 facilities in Maryland over the next month or two, and we'll have a network that pretty much covers the whole state. So what I'm here today to talk to you about is how do we work together as business people with what you all are trying to accomplish, okay? And so that's the basic background. And then I want to give you a little bit of history. We have a related party company called NPH, so you see the slide for that. NPH has been an integral part of what we're doing. 5 years ago, we started saying to ourselves, the system isn't going to support what's going on. The constant increases in the cost of health care isn't going to support it. How are nursing home owners going to be part of the solution? And we said, okay, if we can reduce our cost to the system, someday, some way, we'll figure out how to make some money with it. So 5 years ago, we started making an effort both with IT systems, basic health information systems. We spent about $1.5 million creating our own data mining system so that we could really know what was going on with our patients and keep them healthier. Because the best way to reduce the cost of care in the system is keep our patients healthier. It really is a nice way to keep them out of the hospital. We hired a guy away from the state. We hired Mark Kerwin, who was a 25-year state surveyor, 25 years in the Air Force Reserve. Some of you know Mark had reached the level of being a full colonel in the Air Force, did 9 tours of duty in Iraq and Afghanistan. And we said, Mark, we want you to look at our numbers. We want you to gather them, make sure they're accurate. Look at not just readmissions, but look at admissions. Understand why we have people that go back to the hospital. Understand how we're a good partner. Set up the committees with our hospital partners. And he started to do all of that for us. We also put nurse practitioners into our facilities. We created step-up units. Step-up units are higher acuity units within our centers. So they can take a patient who in some of our facilities needs dialysis or a respirator. We can take patients that are sicker and, I'm sorry. Don't worry about the slides for now. I'm not going to stick to them anyhow. There, you guys can look at later. I'll get to put all the points in them, I promise. And you know, how could we pull all these pieces together and have an impact? So what we were able to do, we bought, for example, 5 facilities in the city of Philadelphia. We own 25% of all the skilled nursing beds in the city of Philadelphia, 1,200 beds. We bought them from New Cortland Presbyterian Charities, a really good organization that has done a great job with these buildings. But the readmission rates, despite the fact that they were 4- and 5-star buildings, they get deficiency-free surveys, hard to imagine in a 400-bed building you get a deficiency-free survey. We've gotten a bunch of them there. They were able to, they were doing a great job, but their readmission rate to the hospital, ready for this, was 45%. 45% of the patients that walked in the door were going back to the hospital because that was their attitude. If somebody got a little sick, ship them out. Let's not try to take care of them here. Let's get them to the emergency room. When these people show up in the ER, they get admitted. You see an 85-year-old with Alzheimer's, I don't care what they've got, the tendency in hospitals to this day, no matter all the efforts you guys are making, is to admit these folks. Okay? So we got that readmission rate down from 45% to 17% in a year and a half. Okay? In Maryland, we started at about 24%, and these are the numbers done the right way. You ask anybody in the nursing home industry today, they'll tell you the number is 15% or something. And it can't be because it's not in keeping with what the averages are. The point is we have Mark Kerwin who makes sure we track them the way the federal government wants us to track these numbers. So we went from 24% on average down to around 11, 12%. Some of our buildings are down to 6 and 5 and 3%. Okay? And the reason for that is we put the pieces in place to be able to drive those costs down, drive those admissions down, keep those folks healthier and out of the hospital. Okay? These are expensive things to do. We don't earn an extra penny from them. Okay? But we do get something with the hospitals now. Because of your efforts, because of what's going on out in the other 49 states, hospital CEOs are starting to look for the first time at which of their partners actually do a good job on these issues. And we're starting to see, for example, in Pennsylvania, we're going to announce networks with 2 of the major health systems there to create a skilled nursing home network, which is only going to consist of skilled nursing homes that have readmission rates below a certain point. They have IT systems that integrate. They have surveys that are at the right level. And they're going to only direct their patients into those facilities, which I think is part of what Lou was getting at, that you've got some facilities that get it and some that are never going to get it. It has nothing to do with whether they're for-profits or not-for-profits. It has nothing to do with whether they're big chains or little guys. Just some of these folks get it and some of them don't. Okay? And the real question is, how do you then steer patients to those facilities that are willing to do these things and make it work and share? I mean, the point of this panel is, how do you share some of those savings with them? Okay? So what we did is in the other 49 states where bundle payments were allowed, through our NPH-related company, we went out and filed to be a Model 3 bundle payment program. And we're one of the first groups in the country to be approved. I think in that first round they approved like 13 or 14 groups for the bundle, the Model 3. Rob can correct me if I got the number wrong. And we were one of those first groups. And we went live with that program in Philadelphia on January 1st. Okay? It is a terribly flawed program. Okay? It's flawed because they got a single rate across the state. It's not based on MSA. It's not based on anything other than the state of Pennsylvania. Okay? Which means if you're sitting in the city of Philadelphia where your folks are with heart failure going to the hospital and getting defibrillators put in, there's a much different cost than if you're out in some rural community where that's never going to happen. Okay? Having said all that, we've managed to drive those admissions, not just readmissions, but admissions dramatically down on those patients. Okay? And we continue to work at that. We've also signed up some number of hundreds of others. It's on here, 209 SNFs and 12 health agencies in 19 states into our bundle program. So we're doing this now across 19 states where sometimes they're taking risks, sometimes we're going to take some risks, but those are all developing. But we actually went live, and eventually the federal government will actually tell us our numbers for the first quarter. We're thinking we'll see number, and this is a real issue for business. We probably won't see our numbers from the first quarter of 2014 until September, October, November of this year. It's awful hard to manage a business that way. Okay? Okay, so having said that, then the question is, what do you do in Maryland? Okay? We have this wonderful opportunity in front of us. You have skilled nursing providers like Lou and others that get it. You have plenty that don't. We can be tremendous partners to reduce the cost of care and help you guys meet whatever tests you need to on Medicare. Okay? There have been some in the Health Association that have said, oh, let's give everybody a 3-day rule waiver. That'll solve the problem. Don't do it, don't do it, don't do it, don't do it, okay? It makes a lot of sense within certain programs. It does not make sense as a widespread, a request by the industry, okay? What I'm suggesting, or I'm asking for help, and that's what these slides talk about, is we have hospitals that have talked to us and are willing and interested in creating programs not just with us, but helping us, having us help them organize programs with their better skilled nursing providers that they typically work with, narrowing down their network, creating certain DRGs they track, and essentially create a Maryland equivalent of the BPCI program, the bundle payment program, created here in Maryland. There's lots of nuances we'd have to work through. However, having said that, we can pick specific diagnoses. We can identify those patients when they hit the emergency room, whether they're coming from a nursing home or they're coming from a community. When they hit the emergency room and they fit the pathways that get created. Some of those patients don't need to be admitted to the hospital, but they get admitted today. There's no other way to take care of them. The 80-year-old with Alzheimer's disease with a simple UTI, I can list 50 different and look into 50 different opportunities that are out there for avoidable admissions. Okay? What we need is a cooperative effort with our hospitals, with our emergency rooms, with the social workers in the emergency room, and with creating the right skill sets in the nursing home to take those patients right from the emergency room. Okay? That program would drill a long way to solving some of the issues you guys have to deal with. The industry, the nursing home industry, if it's smart, is going to cooperate and make this work. Because the last thing they want is for you guys to say, the waiver's failing because of the nursing homes. We need to now take control of the nursing home reimbursement. That will scare the living daylights out of them. Okay? So the better opportunity is for the industry to cooperate and be your best partner with what you are trying to accomplish. To accomplish this, you need a waiver in very specific cases for nursing home hospital combinations that have worked out, partnerships, have worked out what the care protocols are going to be, how we're going to identify the patients, what the protocols are going to be, how the families are going to be worked with, because this is a family education issue as much as anything else. Okay? And those patients can then be diverted from the emergency room, or maybe never get to the emergency room if you got home health agencies involved. Okay? But you can divert those patients from the emergency room straight to these higher acuity units in the skilled nursing center at a much lower cost. Now, what do you got to look at? You got to make sure that we're not taking a 3-day hospital stay or 2-day hospital stay and turning it into a 45-day nursing home stay. Okay? So the skilled nursing facilities in these networks have to agree to utilization management. They have to agree to QA that crosses both the hospital, the ER, and the nursing home. They've got to agree to having their data watched and being part of to stay part of the program. But it'll be a big plus for them and a great incentive to them. A, they'll see more admissions. They may see less days per admission. They're going to have to agree to allow that to be tracked. Okay? The total utilization in the nursing home, if we take the typical patient that comes to the nursing home, we run about 22 days. If somebody breaks their hip, they got 3 days in the hospital, they get their hip replaced, they come to the nursing home, they're there 18, 20, 22 days. Okay? Part of a program like this can also be managing that utilization as well. And the folks, the nursing facilities that are part of it will be willing to do that because what they're going to get is more total admission. They're going to have these partnerships with the hospital that everybody's not going to be part of. And because they're going to get more patients, they're going to be willing to manage their utilization and manage their QA in ways that are going to affect the results you all want, which is a total savings and patients that get good care. Okay? So what I'm suggesting is we need certain areas of help from you all. We need programs that, and we can propose them, and I'm prepared to propose them, very specific programs that the hospitals could look at and say, yeah, we can do that, because they're not all willing to take a chance. Okay? They're all saying, okay, we want to do these kind of things, but we want to see where the commission goes. We want to see where the work groups go. There needs to be sort of a pat on the back to these kind of concepts. Okay? There needs to be an understanding out there that a waiver from the 3-day rule is attainable with your help, because that's a big part of making this happen. And there needs to be an understanding at the hospital levels that they can share some of those savings with the networks of skilled nursing providers that they work with. Okay? I think they have the right to do the latter today, but they need to hear it from you all. So what I'm suggesting is that there is the ability to set up a Maryland-based BPCI program in everything but name. And that there are providers, not all of them, I'd say it's a third to half of them who get it. They're already making these efforts. Would be happy to work with you all but you need to send the word down the line to the hospitals that this makes sense to you all. Okay? And then have the hospitals and the skilled nursing groups come back to you with, here's our specific plans, here's how we're going to gain share, here's the help we need from you all with the federal government. Let's push ahead and make these things happen, because they make a lot of common sense. So I'll take any questions. I skipped all through my slides, and I apologize, but this is the kind of thing we could accomplish in 6 months to a year with your help, and have these up and running. And we're already doing this in other states. It's not like it can't be done.
Yeah, I think this is Dr. Bemba. I think it's an interesting idea. I mean, I've looked into, and they do in other states, triage patients in emergency rooms who have, let's say, back pain, and try to prevent their admission to the hospitals, because once they get admitted to the hospital, they end up spending 5, 6, 7 days just bedridden with pain medications and so forth, to see if an exclusion to the 72-hour rule could be made to have them transferred to a lower acuity setting for that sort of treatment. Is that something along the lines of what you're talking about here?
Yeah, I think we're on the same wavelength. There are clearly lots of patients that, identified properly, don't need to be admitted to the hospital. And now you've done such a great job of creating the incentive for the hospitals not to admit these folks. Now we got to give them the resource to be able to not admit them. Because you got a family that shows up with them, you got to do something, and you're the ER doctor. Let's give them another path that the families can be educated about. That is a much lower cost path for the system.
Hi, Scott.
Hey there, how are you? Good to see you again.
So maybe you said this, but if you go through again, so what kind of services can be provided to the patients in the nursing home facilities and these, what you call it, like special areas?
We have step-up units, particularly up in Pennsylvania, because we already have the BPCI program up there. And what we typically hire is nurses that have worked in the ICUs and the emergency rooms at the hospitals nearby. They're just trained at a higher level. One of our units has a dialysis unit in it. Another has a vent unit. Okay, and those are for chronic patients typically. But they're just more comfortable with sicker patients. Part of the problem isn't that a nurse in a skilled nursing center can't take care of a heart failure patient like a hospital nurse. But they tend to, in the typical skilled nursing center, be folks who want to deal less with acuity. So you need to hire people that are more used to acuity and aren't going to panic and send them to the emergency room when they didn't need to be sent.
Well, it's just very simple. So a patient with Alzheimer's, looks like they have UTI, maybe they're dehydrated.
Yeah.
Instead of bringing them into the hospital, they could go to one center, IV fluids, even IV antibiotics.
Absolutely.
Just to give a
We
flavor.
do this every day. We do it every day. We've been doing it for 15 years now.
Right. And the doctor or nurse practitioner sees the patient how often?
It can be every day. It can be 3 times a day if we need to. In our Philly facilities, because we have so many of these patients, I have full-time nurse practitioners 7 days a week in some of these buildings. And they'll see patients whenever they need to be seen.
Okay, so for lack of a better term, it's like a mini hospital.
It is, but we don't have to support an emergency room or an operating suite or any of the things that bring high cost. I don't have to go out and buy $25 million CAT scanners.
Right. So in a way, this is sort of the equivalent of moving surgery from the hospital to a freestanding center.
Absolutely.
Just a medical analogy.
And it is important to note that there's very, very little to no limitations on licensure for nursing homes. We can't deliver babies. It's one of the things in the regulations we can't do. But that's why it's so important to have this relationship with the hospital, and the hospital meets with the nursing home state. We like to have this type of unit, and they have the involvement in helping build that unit. We don't have limitations on our license.
The typical hospital, Lou put up a slide that I think I don't know if you guys picked up on it. The typical hospital is sending their patients to the typical nursing home by which facility has created the best personal relationship between the discharge planner and the admission person. That was the donut slide that Lou put out there. It is more true than you want to believe. And what we really need to go to is, how do we send patients to the facilities that make the investment in being able to take good care of these patients? And how do we then incentivize these facilities to want to do that? Let them earn dollars two different ways, by focusing patients on the facilities that want to do this and are able to do this, and then in the gain share concept.
Could I interject something?
Yes.
Real quick. So if we were doing population-based attribution type thing, who's the patient's doctor?
Who's the patient? The patient, it's interesting. We have a problem as hospitals do today, of getting doctors to come into hospitals and take care of their patients. Years ago, hospitals took over the control of that with hospitals. In our nursing facilities, we, for the most part, have the same thing now. We have SNFist doctors that we've chosen. We started a group a while back. Lou and others have been involved in it. And one group in town, for example, goes to 60 different nursing homes, and they staff it. So, and they have a single IT system across them to integrate all that. So you could use them as the doc, or that piece can be worked out. But as far as attributing it to how you look at the cost for an ACO, I don't know the answer to that. We have to figure that out.
Do you think the doctors you're talking about would feel like they're responsible for the patient now?
Oh, yeah. Okay. Oh, yeah. And they're willing to be.
I have a question.
Yes.
Especially Lou just mentioned the licensure aspect, and this is one of those areas that I see that the left hand know what the right hand is doing. Why nursing homes may not be limited in their services, are there regulatory limits that you see either through your licensing or Medicaid requirements that would curtail some of these activities that you envision, and what are they and what would need to be done? Because there is no special category for a step-up. Every bed is licensed the same. Medicare, Medicaid, doesn't matter what the payment is. So what needs to be changed on that end?
Yeah, I think the regulatory side allows us to do this. All the lawyers have told us that we're allowed to do it. I think Lou would probably concur with me, and he'll speak for himself. We like strict regulation because what it does is it separates the good players from the bad players. Okay? I have no trouble with whatever we decide to do as it being looked at and making sure we take good care of patients. That's always a good thing.
It is an issue. It's becoming more and more of an issue because as you have facilities geared up towards the true post-acute, they take a portion of their facility, geared up to a hospital. When a hospital sends a patient to a nursing home, part of being good is looking good, and they have to have the clinical, along with the clinical capabilities. So the nursing home industry has taken and come up with their skilled unit. And after a patient stays there and finishes their skilled stay, they say, we don't have any long-term care beds, you have to leave. That is creating a problem. And that is an issue, that's a regulatory issue that we probably need some help with the commission. We certainly need some help with OHCQ because you want to encourage part of the solution to the all payers is to be able to adequately care for a patient at the lowest cost setting. And if what happens with the regulations today, I mean, the state could say, we don't recognize a skilled unit, so therefore, that patient wants to stay in that unit, they can stay in that unit. So that's one of the issues that we have that needs to be addressed as we move forward.
And then just one follow-up question, and I don't know if you operate them, Scott, but I know that you do, Lou, and that's assisted living. We keep talking about the nursing homes, but I would imagine that if an assisted living could meet many of these requirements, they could also serve this purpose with working with their hospital.
Absolutely. They can be a post-acute provider very easily and with higher patient satisfaction being in an apartment, their own private apartment. Yeah, I think there's certain things that can be done, of course, with proper staffing.
Okay, thank you.
Who makes the determination of whether they should go to the acute care setting or be transferred to the post or to a skilled nursing facility? Is that just based on an algorithm? Or?
Well, it's an algorithm with a thought process. I mean, you got to be careful that when you create algorithms.
How are the specialists who, let's say, a cardiologist or involved in the process and process improvement and making sure that the care is appropriate?
Yeah. I think what you're going to need to do is have an educational process with your emergency rooms. You know, the day of hospitals encouraging, and probably somebody will deny that this happens, but it does. The day of hospitals encouraging admissions has probably gone away in Maryland in their emergency rooms. I think what you're going to see now is an educational process that goes to these discharge planners, the social works, the other people that are sitting in the emergency room on which patients would be appropriate for a program like this. I think you sit down with your specialists at the hospital, in each hospital, and you figure out your pathways. You know, if the patient has A, B, C, and D, they could be appropriate for this kind of placement. And then, you know, like everything in medicine, there has to be judgment, and you have to allow people to use some judgment. But you do want to encourage people, if you create these pathways, you want to encourage folks to use the pathways. You want to measure how they get used and what the outcomes are.
Were they included in these special, were they included in the bundles and the gain sharing, shared savings and the programs you're referring to?
In Pennsylvania, what we've got in Philadelphia, we have partnerships with Temple, with Einstein, and I think several others, where they're, and Rick, who's with us, can comment on that if you'd like. But we have gain share agreements with several of the hospitals, major hospital systems. They are downstream from us. The hospitals didn't go out and get the bundle payment program. We did. They looked at Model 2, which was hospital-centric, and they decided not to go there for whatever reasons, and I would let them comment themselves. Instead, what they did is they joined our program. We manage it. We work out pathways with them. We've worked out gain share agreements with them. And that program is actually working fairly smoothly, and we're getting admissions through the program that we're tracking. We then hired what we call nurse navigators. These are nurses who track the patients in the ER, to the nursing facility, and then home. They track them for 90 days into their homes. We have a single home health company, for example. We used to work with 9 different home health companies. We narrowed that down to one home health care company, and they're actually identifying people at home that have some deterioration of their status, and we're bringing them back into our step-up units, which are, again, as was pointed out, regular nursing home beds, licensed, but with a higher acuity ability. So we're bringing them right from the community and never passing through the emergency room, and we're doing that fairly routinely with the help of the home health care folks. So a good example of that is the heart failure patient who picks up 5 pounds. They may not be symptomatic. They may be mildly symptomatic. You certainly want to treat them before they become symptomatic. You bring them into the step-up unit. They get some IV Lasix. They get their blood pressure monitored. They get watched very carefully in their home in a day or two, and they never hit the emergency room. Because if you wait 2 more days and you're not picking them up from the community, they get to the emergency room short of breath, and now they're getting admitted. Okay? So those kind of pathways really are working up in Philly.
Scott, I had 2 questions. First, you referred a couple of times to the 3-day rule.
Yeah.
Could you describe that for everyone?
Sure.
And let me ask my second question, too, so you can do both. The second, I'm not sure about this, but I think that the revenue at the nursing home is actually higher during the first 30 days after a hospital discharge. I'm not sure of that. And that, so therefore, there's this odd incentive that after 29 days, the nursing home is actually there's an incentive to send the patient back to the hospital so then they can get the patient back and start that 30-day clock over again. I could be wrong about that, but isn't there some odd business where actually nursing home revenue goes up because of readmissions? But could you comment on both those?
The latter question, I've never heard that discussed in our organization at all, I got to tell you. Lou may know more of the particulars of how the reimbursement works, but we typically are having people go home, depending with anywhere from 3 days to 40 days, depending on the situation. I think there's a co-pay difference for folks after certain, and I think that's what he's referring to.
Isn't it Medicare coverage? It's the Medicare on top of the Medicaid.
The Medicare benefit for a patient is actually 100 days. We never get anywhere close to that. Okay? It's 100 days, and look, ideally, as a business person, I'd love to be able to justify how I take care of somebody for 100 days. The reality is that the rules are if somebody's not making progress with their therapy, they have to be discharged from the Medicare program immediately. Some of those people go home. Some of them go to long-term care. Some of them go to assisted living. Most folks go home. I mean, 95% of our admissions go home. Okay, it's a different world than it was 30 years ago. 95, 96, 97% of all admissions go home at this point. to the first question about the 3-day rule, the 3-day rule is that we cannot admit a patient for a skilled benefit. Okay? In other words, take care of them with the funding to take this higher level of acuity care of them until they've been in the hospital for 3 days. It's a silly rule. I understand why it was created. It addresses some bigger problems. But in today's world where we're trying to figure out what's the right setting for patients, it doesn't make a lot of sense. But I would argue to you, if you just get it relaxed across the board, it'll get taken advantage of. If you relax it in programs where there's case management and QA and real partnerships between the hospitals and the nursing facilities, it makes a lot of sense. And then you can measure it to make sure it's not blowing up the back end, which is the nursing home costs. So if your nursing home cost is $500 a day and your hospital cost is what today, guys? You guys are the experts, a couple of $1,000 bucks. There's a big difference there, but you don't want to have 20 nursing home days to substitute for 3 hospital days. There won't be any savings. So it has to be part of a program where you're measuring these things, and the participants in the program are all incented to keep those costs down.
So just to ask a question, you said before when you were describing this, it could be a Maryland version of BPCI, and in the slides you talk about risk. So I think what you're saying is that the idea is that in BPCI, someone is actually at risk for the total cost. So you keep referring to making sure that the costs on the other side don't go up. I mean, very specifically, I think what you're saying is you're at risk. In BPCI,
I'm happy to take
you're at risk. So you've guaranteed that the balloon, when you squeeze down over here, it's not going to come up over here. That's guaranteed as part of the BPCI or could be as part of the Maryland. And then I think the other...
Well, let me address that real quick, Rob. Just you say, I believe we would, and I think there are other skilled nursing operators in town that, given the right tools, given that help on the 3-day rule, given the right tools, would be willing to look at the total cost of care for these patients and take risk, either alone or side by side with hospital partners. They'd be willing to do that. I'm sorry, I didn't mean to interrupt you.
No, and it sounds like the big difference, a big difference versus BPCI is in BPCI, it is, my understanding, is it's post-hospitalization, so discharged from a DRG. The concept here is that we could have episodes that don't begin with a discharge, they become with a clinical condition. They begin with an ER. It could be a discharge from the ER as opposed to a discharge from an inpatient stay.
You can even
look at a hospital. You could use data to calculate episode costs.
Let me throw another thought at you. You could look at a hospital system. Take an isolated one like a Garrett Memorial or somebody that's fairly easy to measure what's going on in their community, and say, okay, let's put this into place, and let's see what happens to the total cost of care in that community, and take risk on both sides of that. That would be an awful neat experiment to go down the path of.
One question is, in order to get the shared savings, if they're going to the emergency room of the hospital or even out in the community before they go into the nursing home, then that would assume that the hospital gets to keep those savings from those reduced admissions, as opposed when we're going to be paying for the care in another setting. And that's one of the things that has been discussed from the HSCRC that says if that care is just being shifted to another provider, we're going to take that out of your rates because payers aren't going to pay for it twice. So I think with your assumption would have to be that the savings are actually, that the money is actually staying with the hospitals in their rates so that there is that mechanism in order to do that shared savings. And I don't know what from the HSCRC standpoint, that sort of is a different dynamic than what we saw.
Removing it from the system lags dramatically behind, the savings, so that you get your savings, but maybe it lags behind.
Yeah, or it's as Kim said, I think the basic concept in BPCI, if the target is for a particular episode is $30,000, there's 15 in the hospital and 7.5 in the skilled nursing facility, and some in physician and some in home health. I think what I'm envisioning is the 15 that's in the hospital stays in the hospital, And at the same time, it's all wrapped up in a risk-based program where the person is guaranteeing that the other 15 won't go above 15. If the other 15, if the whole thing goes to 31, they owe you $1,000 back. But the portion stays in the hospital, and at the same time, there's a guarantee around the package. But I would agree with you that the hospital piece stays in the hospital, and then you got sort of everything else.
Yeah, I don't see how the math works with the hospital piece staying in the hospital. So that really, we'd have to get the devil's in the detail with the math. But if we're paying for something new outside of the hospital, then we would need to make sure that we pay less inside of the hospital in order to balance that picture out. But those are certainly details that can be worked out if folks are willing to take full risk for the cost of the services, because I think that's really the bottom line in terms of any sort of bundled payment approach that deals with post-acute, is that the HSCRC wouldn't be able to promote something that would cause an expansion of cost in the system, and therefore it would be important to make sure that there was actually not an expansion of cost as a result of the program. And I think that's been said, but just to say that again, that we have to make sure that there's no expansion of cost. And Dr. Nguyen made an analogy to ambulatory surgery, but I don't think that there is really an analogy to ambulatory surgery, because there's one patient and one surgery, but that isn't the case in long-term care and post-acute care. The side of demand is not so clear versus a surgery, and so their demand can expand for a program, and we've seen a little bit of that in the observation area, where we've seen more observations being done than reductions in one-day stays. And so we have to be very, very careful when we introduce a new concept to make sure that we don't do more of them thinking that it's going to save money, but it's actually just expanded the supply side and therefore the demand side for the service. And so it's a cautious walk, if you will.
In addition, we've talked about the hospitals, the skilled nursing facilities, and people making decisions, but if an ER physician has to make a decision, are they attributed and are they part of a gain-sharing mechanism? Because they've prevented an admission as well.
Well, you can certainly do that as long as you tie it also to outcomes. What you don't want to do is to come back later and say, well,
I think they're an integral part. If they're making a decision or they're involved in the process of making better decisions, then they have to be involved in the process, in the shared savings as well. And there has to be a way of doing that. If it was going to be attributed to the hospital and then trickle down to them, if the hospital is not getting much, there's not going to be much for the physician to get from that. So.
Yeah,
I think the medical community, the physician community, also wants to be involved. After all, I'm sure the process isn't perfect as it exists, and the process is going to need improvement and input from the specialist community over time.
I suspect you can include lots of folks that are along this pathway in the gain share, and figure out ways to incent them both on the quality side and on the cost savings side. And I'd also, getting back to the point, Donna, that you made a moment ago, I think there's enough savings in this concept that there's a way, if we sit down with, and we already had some of these discussions, sit down with some of the leadership in hospitals, we can figure out a way that the overall cost of care doesn't go up, it certainly goes down a bit, it certainly controls the increase in cost of care, and enough remains at the hospital to cover some of their fixed costs. But I think there's enough savings, and I don't think on the skilled nursing side we're expecting such a huge piece of the savings that it really screws up the overall equation. But I think we can come back to you with a program that I think you'd be happy with.
Yeah, when I said remained in the hospital, what I was thinking was remained in the rate, and then what I meant was remains in hospital rates. How they then reinvest them, the same way you'd invest in care management, you may take some of that in rates and invest, but you've guaranteed that in my example with 30, the 15 outside of the hospital doesn't go above, and you've guaranteed the whole package. The 15 some of it may be reinvested outside the hospital. So you don't start by changing the hospital rate.
For clarification, Dr. Rifkin, you said that 95% of your patients go home after they're admitted. You mean your Medicare patients?
Keep this in mind. Almost everybody we admit today is a dual eligible. And I always hear about dual eligible. Either they're dual eligible or they become dual eligible in our facility. But almost everybody we admit when we come in at least has Medicare. The vast, vast majority, 90-some% of our admissions. Of our admissions, about 95% go home. The 5% that stay become our long-term care patients, and they eventually either already have Medicaid and they switch over to that being their benefit, or they get qualified for Medicaid because they spend down and do other things, and they become long-term care patients. But it's less than 5% today that even though they occupy a lot of beds, we have such a quick turnover of the other patients, we're already the step-down unit of the hospitals. Now the question is, how do we add the services and the partnerships that make it work better for the system? We're already the step-down unit.
We should probably soon transition to Nicole.
Can I ask one quick question about the shared savings? So Scott, in the model that you have, and I see it kind of conceptually, it makes great sense to take care of people in unregulated and lower cost.
Well, still regulated, but yeah.
Not regulated by
you guys.
Okay. Yes.
We have lots of regulators who show up on our doorstep.
But not by HSCRC, so not on the hospital global budget piece. But when it comes to the shared savings, now there's a lot of straws dipping into that small pool of shared savings. There's ACOs, the potential for ISSOs, PCMH programs. Everyone, with a claim on those shared savings. How do you see that pie being divided
I think you guys are going to have to figure that out. But all I'm saying is that I think there are very discrete.
You mean you guys? You mean us guys here? Or
all the people around this table, right? These guys. But I think there's an opportunity for very discrete, very clear partnerships between very identifiable folks that are going to take responsibility and have tremendous incentive to make this work. With all the other models you guys are working on, I got to tell you, I'm just not privy to, and I just don't know. So if it fits into some other model you've already created, I get that, and I'm happy to discuss that. All I'm saying is this model would work, and we can make it work. And we're willing to take the financial risk behind that.
But it could work as part of an ACO model or an ISO.
I think the ACOs I've seen are a stinking mess, with all due respect, okay? Okay? I'm sorry, guys. I'm watching them around the state. I'm watching the docs in them. They're not really very incentivized to care that I've seen. I'm not saying they're not, but it doesn't seem like it's – you guys do tell the results. I don't know if the results are good or bad at this point. I just don't know how you control that. It's too big.
Yeah, but the process that we're in here is engaging the physicians in those programs and aligning the incentives. So we wouldn't want to do anything that would say that's a bad idea.
I had a guy from an insurance company the other day tell me, he goes, I said, how are you going to be taking a huge amount of risk all over the country on BPCI programs? And I said, how are you going to get the docs to do what you want them to do? Because you're not the payer. You're not the payer. You're not doing utilization management. How are you going to get them to behave? Well, we're signing them all up to gain share agreements. I go, okay, I was practicing doc for 20-some years. I said, how much are they going to earn out of that gain share agreement? Well, somewhere between up to $4,000. I said, well, of that $4,000, what are they most are going to get? We guess about $500. I said, I'm sorry, the physicians for $500 aren't even going to know you exist. And I believe you can do all that stuff, and maybe you have enough controlled docs in these big ACOs to get behavior. I don't know that. You guys are probably right that it'll work. All I know is if I have a very small program with very specific incentives that I can really get involved with the individual folks, I can make these little programs work. On the bigger scale, I don't know. I hope they work. I just don't know.
Lou and Scott.
A lot of subtle guys, so you ask me a question, I'll give you an answer.
Yeah, we're going to need to.
That's okay.
Yeah, we're going to need to transition to. I think so. Our committee is alignment and engagement. It's physician alignment and engagement, but the work group was also specifically charged with creating alignment and engagement with other providers. if you look to the sort of the charge of the work group, and post-acute was one of the specifically named charges that came from the advisory council. So there's a little bit of a disconnect between the name of the work group and the things that we were charged to do as a work group by the advisory council. So it's very much just within the realm of what we were charged to do. And with that, I do want to transfer it over.
I will go very quickly.
We've been trying just two quick things, and Dr. Nguyen. I guess questions that just jump up. This is a complex thing, but one is the Emtala Act, the Emergency Medical and Active Labor Act in the hospital, make sure, and the physicians making sure that the patients are stabilized. I know that there's a lot been going on very successfully in terms of patients that come into the emergency department that don't need inpatient stays going to observation. And I know when the emergency physicians are involved in that, and some pilots in the state, it's very helpful, as well as looking to transitioning those patients into the community. So I think we really need to think in terms of that continuity as we look at what you're suggesting. So with that, I'll turn it over to Dr. Nguyen.
Yeah, just 30 seconds. The ambulatory care facility analogy was really just these services can be provided clinically appropriately in different places in the hospital. And if you think about the demographics of the Medicare population, people do something like this, no chance. I mean, almost everybody's over 85.
So I'm going to pick up on a theme that Donna mentioned earlier, and that is to discuss things that are available today that should be capitalized on, should really be built upon, that I think are getting us to where Lou described where the industry needs to go, and to be able to contemplate the business proposal that I was hearing from NMH and Rob. I think there might be some issues. I apologize for folks following on the web. There might be issues following my slides. I was asked to talk about our Transitions Handle with Care initiative, and you might have heard of the name. You might have seen the logo. What we don't really talk about very much is the tagline, Partners Preventing Avoidable Readmissions. And we realized early on that to be successful in this new era of healthcare delivery, hospitals need partnerships. And so we established this initiative a little over a year ago, all around that concept. And thank you. And really focusing on 3 key things. Fostering collaboration. This is a multi-stakeholder, statewide initiative focused on fostering collaboration across providers, using data strategically, and embracing evidence-based practices that are implemented locally. Collaboration happens at 2 levels. At the local level, we asked hospitals that were participating in this initiative to form cross-continuum teams. These are teams of, it started off small. These were the nursing homes and the home health agencies that they already had routine business with, that they had great referral relationships with, and those have been growing. To look at every readmission as if it is an avoidable event. We asked hospitals to use a tool from the Joint Commission, the Targeted Solutions tool, that really targets handoff communications between senders and receivers, identifies defects, and implements change. Over the course of the past 15 months, we have been offering webinars. We've done 12 webinars to date, 4 of which have been focused on nursing facilities, because we think that's where a lot of opportunity is. We've done 2 statewide meetings with our partners. Every meeting, hospitals come with their partners. They come with nursing homes, with home health agencies, with community-based organizations like Meals on Wheels and Healthcare Access Maryland, which was discussed earlier. And we provided direct technical assistance to hospitals that were really trying to figure out, by looking at their readmissions data, why folks were coming back to them, where they were coming from, and what should really be a good business relationship. So I think I completely agree with some of the comments earlier about where care is going and the strategic decisions that hospitals are making with respect to who they are partnering with. We put all of these strategies together in with the image you have in front of you, and I have one with me. I'm happy to share it. This is our readmission reduction playbook, version 1.0. It has all of the hospital-based strategies in place. It's available on our website. Anyone who's interested can download it. And you turn your slides to the next page, you'll see the table of contents. So the three things that hospitals are working on, we talk about using a portfolio, a multifaceted approach. It's very old school to think about your readmission reduction strategy focused on just CHF patients. So really using a portfolio approach to improve the standard of care for all, risk assessments on every patient, teach back for every patient, discharge phone calls, follow-up visits, home visits as necessary, to improve the transition across the continuum. So we have in the playbook and have been working on this for the past 15 months, high leverage opportunities, and we focus on skilled nursing facilities, home health, hospital to home with services, so that would include assisted living, which we were talking about earlier, and also emergency departments. The most effective way to prevent a readmission is to not have the admission in the first place. So we talk about evidence-based structures in all of those places. And then finally, we talk about transitional services for high-risk patients. So these are Medicaid, behavioral health, palliative care. We're just not following. Okay, so the next slide. So collaboration at the statewide level, we have a care transition steering committee. And on your slide, you have the logos of all of the organizations that are part of that steering committee. This is a broad distribution of payers, providers, community-based organizations, consumer advocates, and state agencies. And we're all coming together with figuring out where our agendas align to mitigate barriers and to accelerate change. So we have all of the post-acute provider associations represented. We have the hospitalists represented because we've been really working in that regard, and the community-based organizations as well. We inform one another's agendas. We talk at each other's meetings. We have our boards meet with one another's boards. We cross-pollinate educational opportunities and trainings. 2 weeks ago, Dana, we had a statewide meeting, Lifespan, the Maryland National Chapter Home Care Association, and MHA supported it, where we had hospitals sitting with their post-acute providers, talking about evidence-based strategies, really working through how to be effective partners. And my boss, Carmela Coyle, gave the keynote at that address, and she talked about why, more than ever, it's really important that hospitals focus on the post-acute setting, in particular nursing facilities. We know that Medicare readmissions drive all payer readmissions. We know that patients that are discharged from a nursing facility are more likely to be readmitted than any other setting. This is where we need to be focused, and there are opportunities, there are evidence-based practices that are already available. So our steering committee has formed 4 subcommittees, and one is focused specifically on readmissions from skilled nursing facilities. And Donna and others around this table have been part of that group. We're really focusing on 5 areas, and if you are able to really track the driver diagram, I think you could follow. The first is improving handoffs from skilled nursing facility to hospital. The 2 long-term care associations are asking their members, are you using a standard form? Is it the Interact form, which is really the gold standard evidence-based practice? If it's not Interact, what are you using and why? Have you developed it with your hospital? Really making sure that there's something standard there. We are focusing on care preferences, not just, Maryland's essentially a universal MOLST state. So not just completing the MOLST, but making sure that providers have access to the MOLST, having preliminary discussions with Chris to have that MOLST form be uploaded into a specific part of the query portal so that it can be accessed, to make sure that we're really taking care preferences into account. Focusing on local relationship building. This is getting to know your local providers. Multiple hospitals have put out RFPs to their skilled nursing facilities asking about readmission rates, using CRIS, discharge disposition stats. Do you have chronic disease management programs? Do you have palliative care? And they will make those decisions regarding what that network is. So this isn't just happening in Philadelphia. It's very much happening in Maryland. And finally, training and Interact. This is a place where the Hospital Association really put our money where our mouth was, because we sponsored a statewide training last summer. We was there, a 2-day session where we brought the founders of Interact down to do a 2-day summit, and we trained 85 nursing facilities. We had 120 people attend that training. And we want to continue to make sure that providers are aware of Interact. The Senior Vice President at the National Association for Long-Term Care, ACTA, said in December at a national readmission summit, I tell hospitals if they are working with a skilled nursing facility that is not implementing Interact to find another skilled nursing facility. That's a very strong statement from their parent organization, and we're telling our hospitals about it, and I know that the long-term care associations are doing the same. And we want skilled nursing facilities to be connected to CRISP. We think that readmissions data is important to inform where to target for improvement. We know that that's a longer-term approach, but just recently, just a few weeks ago, the HSCRC agreed to require hospitals to capture facility names for admission and discharge disposition. So over time, we'll be able to create those readmission reports to really drive strategic partnerships and decision-making. These are the areas that we think will move the needle. These are the areas where we are encouraging hospitals and skilled nursing facilities to work together to lean in year 1 and year 2 to really make a dent in our readmissions waiver targets. It doesn't require waivers. It doesn't require, it just requires the effort and the time and the partnerships. And I know we're over time, so I'll conclude there. Thanks.
Yeah, no, thank you.
Again, we are over time, but I feel the need to really interject here. I understand the work group has been tasked with a lot, and here we are in the final hour quickly going through post-acute, and now I feel like post-acute is being further reduced to skilled nursing. And there are a lot of post-acute opportunities that we haven't even had a chance to explore. Earlier in the work group, we've had some really good data on the SIM data that you presented. We know a lot about high readmit zip codes, community health hubs, telehealth, inpatient rehab, outpatient, home health, Medicare B in the home. There are a lot of post-acute opportunities, and I just want to make sure I'm feeling really crushed right now and really focused on SNFs, and I want to make sure that the work group is going to go broader.
Yeah, no, absolutely. We agree. We've talked about care coordination in general. We're charged with care coordination in general. I'd highlight that the programs they've talked about, like the BPCI program, is fully, it happens to be proposed by a SNF provider, but they are fully accountable for the episode of care, including all Medicare covered services. And I think that was kind of the point, that you work with a home health agency that's part of the process, and you're managing that episode of care, including all the Medicare covered services.
So we need to make sure that we have good data on episode of care. We need to make sure that we're looking at functional assessment tools, patient-reported outcomes. So this is June 4th. I'm seeing June 25th. I'm just, concerned about making sure that we don't fast-track through a lot of those nuances. And also Barry's continued mention to the charge master for discharge planning is huge. Yep. There are a lot of nuances to this. Functional mobility is huge. A lot of the decision-making is really important in terms of whether or not the person has good functional mobility, how far can they walk, how are they with their ADLs, where they should go. That's a really important piece.
I think one of the things that we're doing in all of our work groups right now is assessing where we are and really kind of setting the, a game plan of where things need to go and how they need to be processed going forward. And obviously there's a lot of work in front of everybody. So I think your comments are very helpful in terms of trying to look forward to the magnitude of work that actually needs to be done in this area, and realizing that we've really hit Chapter 1 here, but we really haven't just opened the front cover on Chapter 2, and really trying to make sure that we really elevate how much work there actually is to do to take on some additional topics. So thank you for your comment.
Yeah, that's the piece that we didn't get to today, which we said we'll put off till the next meeting. But a key part of the idea of the future work is on the agenda. Care coordination is meant to be.
Then maybe I'm misunderstanding the deadline. I thought the next deliverable was at the end of June.
But that deliverable is likely to be step one. The deliverable is going to include where this bundle of work is going to go to. So I think part of the deliverable will be creating a transition plan on how and where this continues. Okay. Thank you.
Reality is